our colleague Dr. Mohamed Dahab.
17-year-old male who is in stage kidney chronic dialysis 1996. His original kidney disease was hereditary nephritis. He has two brothers with end-stage kidney disease and underwent kidney transplantation at our center with negative consanguine. In March 1997, he underwent kidney transplantation from his mother, 52-year-old, with same blood group, 3/6 mismatch, his basic immunosuppression with steroid cyclosporin azathioprine, and little serum creatinine, both chart 0.8, and serum creatinine basally 0.8 milligram per dl. In the 5th day post-transplantation, patient presented with rising serum creatinine from 0.8 to 1.5 milligram per dl, managed empirically by pulse steroid and graft biopsy who revealed acute rejection, which managed successfully by pulse steroid, and serum creatinine decreased to 0.8 again, and immunosuppression remained as steroid cyclosporin azathioprine. 1 month post-transplantation, patient presented with rising serum creatinine again to 1.5 milligram per dl, and graft biopsy here managed mild acute cyclosporin toxicity without rejection, and managed by shifting patient from cyclosporin to FK, and serum creatinine returned to 1.1 milligram per dl. However, the patient developed post-transplant diabetes. In December of the same year of transplantation, patient presented with recurrent attacks of fever, cough, weight loss. Sputum culture was negative, however, sputum generative PCR was positive. The patient diagnosed as TB and managed by quadruple antibiotic therapy. However, the patient increased the dose of FK up to 50 milligram per day to achieve acceptable level. In June 1998, patient presented with high-grade fever, intractable headache, vomiting, diplopia, stable conscious level, right side hemiparesis monotomy on the upper limb, and convulsions. So CT was carried out, which revealed two fairly defined space occupying lesions at the left occipital lobe with perifocal edema and massive effect on the left ventricle. Patient managed initially with ICU admission, anticonvulsant, antibiotics, and storage of azathioprine and urgent neurosurgery consultation, who recommend urgent surgical drainage of the brain abscess. Cytology from the aspirate revealed separate dyspnea, a wide counter-sensitivity, revealed start with antibiotic, broad spectrum antibiotic. After 2 weeks of broad spectrum antibiotic, there is slight reduction in the size of the space occupying lesion of the brain abscess, and neurosurgery consultation recommend another course for 2 weeks. After another 2 weeks, there is complete resolution of the brain abscess by CT, and the patient was clinically free. This current situation, 2014, serum creatinine 1.6 milligram per dl, maintained on a small dose of steroid plus tacrolimus, and he is diabetic on insulin. And despite of all these afflictions, this patient graduated from the high school with high grades, and then graduated from School of Medicine Qasr Al-Aini. Currently he is ENT specialist, married, and has 1 son, and preparing for his MD thesis. Brain abscess is classically consists of central area of necrotic debris surrounded by fibroblast. There is many organisms that may cause brain abscess and may disseminate from many sources. However, in transplantation, the most common organisms are Toxoplasma, Mycobacterium, Nocardia, Cryptococcus, and Listeria. Treatment include starting IV antibiotics, hyperbaric oxygen, which reduce the intracranial pressure and maybe act as bactericidal and optimize the immune function, and beneficial in cranial osteomyelitis. However, surgical drainage of the brain abscess remained the standard management. There is a review article in 1997 talking about abscess in brain abscess in post-transplant recipients receiving cyclosporin-based regimen. And the incidence here is 0.6 in liver transplant, 0.3 in kidney transplant, 1.1 in heart transplant, and the overall mortality is 86%. And complicating factors are retransplantation, anti-rejection, presence of viremia, and multi-organ failure. The lung was the primary site of dissemination in most of these cases. And this review article published in 2014 is discussing the immune monitoring strategies to predict the risk of infection in solid organ transplantation, and divided these strategies into non-pathogen specific immune monitoring and pathogen specific immune monitoring. The non-pathogen specific immune monitoring, there is multiple strategies such as serum complement factor monitoring, especially C3, peripheral blood lymphocyte subpopulation, especially CD4, soluble CD330, and functionality of ATP in CD4 T cells. These strategies have advantages and many limitations, so it is under trial. Pathogen-specific immune monitoring include monitoring of viral infection, mainly like CMV, Epstein-Barr, PK, and all of them is still under studies. And however, quantiferon CMV assay is commercially available. In conclusion, infections are the major cause of morbidity and mortality in kidney transplant recipients and may be preventable. Care for pre-transplant screening, immunization, post-transplant prophylaxis may all reduce the risk of post-transplant infection. Thank you.